Hi everyone, welcome to our GI Connect newsletter on early onset colorectal cancer. It's a pleasure for me to be here with a friend of mine, a colleague of mine, who is also an oncologist with focus in GI cancer, who is Hans Prenen from Belgium. And we are going to discuss about early onset colorectal cancer. Welcome, Hans.
So I will maybe start by saying what's the definition of early onset colorectal cancer. It's defined as colon and rectal cancers diagnosed in persons less than 50 years of age. So we know that in the US and other high-income countries, there's an increase in cases of early onset colorectal cancer. It's important to mention this is not the case in all around the world. It seems to be more in the high-income countries. And for example, in the US, the incidence has risen from 8 cases per 100,000 in 1988 to around 13 cases per 100,000 in 2015. So this is about 10% also of all new CRC diagnosed. So it's still a subgroup which is rising. And one of the key questions is whether early onset and late onset colorectal cancer are the same disease. And if early onset colorectal cancer is caused by a unique underlying mechanism that is maybe impacted by different risk factors. So what are these potential causes and risk factors? We know that most cases are sporadic, so hereditary syndromes are a bit more frequent in early onset colon cancer, but still it's worthwhile mentioning that the incidences of familial syndromes are stable. So this is not explaining why there is a rise in early onset colon cancer. It's important to mention that 1 out of 6 patients, you can find a pathogenic germline variant. So very important to ask about family history in this group of patients. So what are then the risk factors? There is more obesity, specifically abdominal fat. We have also the use of more red and processed meat in Western countries specifically, as well as processed sugar. And also, of course, I don't have to tell you, we have a more sedentary behavior. We ourselves sitting in the desk a lot of the day is not good for our risk for colon cancer. And all of these factors, they are influencing the gut microbiome. We will not go into detail, but the microbiome can alter the inflammatory and immune environment, and that can influence carcinogenesis. So we know the microbiome plays an important role, but we still try to figure out what's the exact role in the carcinogenesis of colon cancer.
Actually, talking a little bit about disease characteristics in early onset colorectal cancer, we know that more than 70% of those patients have tumors located in the left colon. So this is a unique thing that we see among early onset colorectal cancer patients. So the disease tend also to have like higher rates of poorly differentiated tumors and sometimes more frequent signet ring cells. Also because those patients, they have a higher incidence of Lynch syndrome, which you already mentioned. There is also a higher risk of metachronous disease among those young patients, and also more advanced disease or more advanced stages of diagnosis. So maybe because tumor biology may be a little bit more aggressive, or probably because of delayed diagnosis among those young patients. Another issue about clinical presentation is that the most common symptoms among young patients are hematochezia, abdominal or pelvic pain and bloating, and also change in bowel habits. So those symptoms are also typical regarding distal tumors, and the symptoms frequently are attributed to common benign conditions. So sometimes the disease is diagnosed at later stages because of that. And also there is less awareness of colorectal cancer among young patients and also among healthcare providers, which make the diagnosis even later. And talking a little bit about molecular features of early onset colorectal cancer, so we see a little bit more of MSI-high tumors, especially because of Lynch syndrome. So 1 in every 6 patients with early onset colorectal cancer have Lynch syndrome. And there is a question that is still debatable about the distinct molecular features between early onset and late onset colorectal cancer. So there are some controversial findings. Some studies point towards some small differences about them. For instance, there is one study that showed that APC, KRAS, and BRAF are more common among older patients. And for instance, TP53 and CT and NB1 are more frequent among early onset disease. So I think more studies are needed so that we can really find out that we have really different molecular features between early onset and late onset colorectal disease.
I think also what is important to mention is that patients below 50 is still a large group. You also have patients that are diagnosed at the age of, let's say, 20 or 25 or even younger without having a family syndrome. And if we look there into their molecular data, you see that they sometimes also have different molecular features than the ones that are maybe a bit older. So I think there's still a field which needs to be studied more and more in the future. So Renata, if you think about, let's say, the treatment recommendations in this group, should we treat them a bit different than we treat with the later onset colon cancers?
Yeah, that's a great question. Unfortunately, we don't have clinical trials trying to answer those questions for us. So right now, I would say that we tend to be a little bit more aggressive with young patients. I think we give more adjuvant treatment for them when we compare to old patients. So sometimes even more intense treatment. For instance, a right-sided metastatic colorectal cancer, sometimes we would give triplet therapy instead of doublet for young patients when we compare to older patients. So I think there might be some differences in our practice. What do you think?
Yeah, I think it's mainly for the adjuvant setting I'm a bit worried, because, we have these long-term side effects just as neurotoxicity. And specifically, if you have a young group treating with this therapy, we are discussing about years now for these 3 versus 6 months of adjuvant therapy. And I think it's very important that we shouldn't over-treat them with oxaliplatin in the adjuvant setting because of the long-term neurotoxicity. The question whether we should give capecitabine versus 5-FU, I don't think it's answered yet. So both options are feasible, but given the recent data, I'm personally more a big fan of giving, let's say, Capox, where you give short-term oxali and then continue with capecitabine, for example.
Excellent. I try to do the same in my practice as well. And what do you think about the impact of colorectal cancer diagnosis and also treatment in the quality of life of patients with early onset colorectal cancer?
I think it's an important one, and this is something we have to keep in mind in all young patients with cancer, because of course we try to cure as many as possible, but once they are cured, we also have to think about the long-term effects and also the effects on their career. Some have a stoma which have to live in, so it has a lot of impact, I think, on these patients. Don't you agree?
Oh, totally. I think it's a major issue, and also about their reproductive health and family planning, sexual health, the issues about genetic counseling, nutrition. There are a lot of problems that those patients face, and also others like psychosocial distress, spirituality and existential concerns, like mental well-being. I think there are many problems that those patients may face during their lifetime living with the diagnosis of early onset colorectal cancer.
I think one last message is that as the incidence is increasing, I think we also have to think about a cost-effective way and also a feasible way to screen those patients. Because if you say, let's do colonoscopy for screening in everybody below 50, I don't think it's feasible, but we're working more and more on, let's say, call it the liquid biopsy or the blood type test for those under 50 to find those few people with colon cancer.
So Hans, what do you think are the take-home messages from this newsletter?
The most important one is that the incidence of early onset colorectal cancer is rising. So just be aware that it's not because you're below 50 that the chance of colon cancer is not there, even if you have just symptoms or maybe slight bleedings or whatever, and that you always ask for family history in these patients, as some patients have also a germline variant. And then also finally, we have to think, but this is more as a GI community, how to find a cost-effective and feasible way of screening patients to find them, because as you know, if you find them in an early stage, we can cure them. I would also like to invite our listeners to go to the GI Connect website if you want to hear more or to read more on the slides which can be found on that site. Thank you.